Okay, so the big job that y'all have today is when we take a break and things like that to make sure I unpause the integrity. Okay? Can we handle that? We think maybe? I know. Okay. All right, we've got it going. Okay, so today we're going to talk about care of the children with respiratory disorders. So we'll kind of review a little bit about the physiology between adults and children, and then we'll go through some of our cases. You will see the stuff that you read over, it may look a little bit different than this, and it's fine. And if you were to slide them all together, they will go together. So just take a deep breath as we go through this. It will be good, I promise. Okay? If not, you can yell at me later after you have candy. Okay. All right. So some of the major differences, when we're looking at children, obviously they're smaller, right? So we talk about children, they're not just little adults, but in this case, yes, their nasopharynx and nares are smaller. What does that mean? They're easier to be obstructed. They get clogged up easier with nice scoopy snot, things like that, right? Smaller oral cavity with a large tongue. They can lose their airway easily, any type of swelling and stuff in that cavity or obstruction. Long, floppy epiglottis. Just when we're talking about any of these tissues along the airway with children, they're just more prone to inflammation. Once they are inflamed, they're more prone to obstruction, causing respiratory distress. When we're looking at lymph tissue in children, it grows very rapidly in childhood, and then generally stops between 8 and 12. This is why we're talking about tonsillitis and some different things like that. Older kids don't have that many problems with it because they've kind of had that stop. The thyroid, cricoid, and tracheal cartilages are immature. So if you were to look, for example, when you're thinking about with adults, hyperflexion and extension of their neck, okay, we can go up and back and we can still breathe, right? Okay, if you were to hyperextend or flex the child's neck too much, it can close off their airway. Okay, so think about if you've got a nice one of those corrugated bendy straws, think about that kind of as adult airway versus if you were just taking like a straight straw and bending it over, it's going to occlude that airway. Okay. Fewer muscles are functional in the airway, so they're less able to compensate when there are problems. The larynx and glottis is higher in the airway. The problem with this is when you have things like inflammation, upper airway obstructions, when you have foreign bodies. You know, kids like to put things in their mouth. I don't know why. Their nose, their mouth, things like that. That makes it easier to occlude and obstruct. Chest wall is more pliable. So that means they're not going to be able to compensate as well. Their chest is relatively round at birth. So you get kind of that barrel chest look on infants, okay? That generally evens out about age 2. If you notice, when we had some of the kids here the other day playing, oops, there goes the candy. When we had, if y'all remember seeing Colton, he was at, you know how old he is, by 18 months or so, 18, 19 months. If you notice, he was kind of top heavy as he was going around, you know, his head and his chest are top heavy. That's why they're more prone to falls and things like that. But they start to even out right about the age of 2. Their ribs are more horizontal. And so you're going to see more of the abdominal breathing. So when we talk about looking at counting the respiratory rate and things like that the other day, this is where you'd look at smaller children and infants. You may need to look here versus here. Okay. Generally, the abdominal breathe till about 5 to 7. Just a fun fact for you. After that, boys may stay to a more thoracic abdominal breathing pattern, and girls shift to a more just thoracic. The diaphragm is more horizontal. You've got those large amounts of soft tissue along the airway. Yeah, that's it. Okay. So all of those fun things make it, they're already breathing at a higher rate. Why do kids breathe at a higher rate? You've got decreased chest excursion. You've got more resistance. Okay, so as they get bigger and their airways get bigger, there's not as much resistance. It's easier to breathe. You breathe at a lower rate. Okay. So what that means is they're already at a higher rate. They're already having increased resistance and things like that. So any kind of obstruction, inflammation, swelling, anything like that is going to put them at a risk. When we're looking at kids and how they compensate, they will go a long time and then they will crash. Kids can sit there and be playing and still be in distress. So it's just something to be aware of. With adults, you kind of watch, and they drop a little, and you watch them a little more, and it's more of a slower kind of stair-step progression, whereas kids, you have to just watch them really close because they will compensate for a long time, and then they'll crash. Okay. All right, so respiratory emergencies, just to kind of review. With respiratory distress, you've got that increased work of breathing, but you have adequate gas exchange. Okay. At that point, they may be, what do you think you'd see with increased work of breathing? You might see some nasal flaring. You might see some retractions. They might be breathing at a higher rate. Okay, so as we move into respiratory failure and they're unable to maintain adequate oxygenation with that, then you're going to see them. Oxygen saturations are probably going to plummet. What else are you going to see? Respiratory rate may drop. They may have bradypnea. What else? Decreased level of consciousness. Things like that. Versus when they have respiratory arrest, obviously they cease to breathe. And with kids, the reason this is so important is primarily the biggest problems we have when we're looking at cardiopulmonary arrest is with kids, unless they have an underlying cardiac disorder, they're most likely to go into respiratory arrest. Okay. So the best things we can do, support the compensatory efforts of the child. So what does that mean? We could elevate the head of the bed if you need to. You remember when we looked at those videos on the assessment day and we had that baby that was having so much trouble breathing, and then they did the jaw thrust on the kid and he's like, oh, I feel so much better and I can breathe. So we may need to do those types of things. So elevate the head of the bed if you need to put a towel roll behind their neck, if you need to jaw thrust them, if they are in a position of comfort. So if they're sitting in mom's lap and that's keeping them calm, we're not going to take them out of mom's lap and go put them on a table and start poking and prodding them, okay, especially with respiratory distress. If they're in a tripod position and they've got their jaw thrust out and they're keeping their own airway open, you're not going to have them lay down. You're going to keep them in that position because they are compensating, okay? We're going to minimize sources of stress, so we want to cluster care, especially when you're looking at infants and small children and things like that and hospitalization, and they're already going to be stressed with new faces and all these kinds of things, stranger danger, you know. We want to go in there and get everything done that we can and then give them long periods of rest, okay? We may need to suction as needed, and so that would depend on the kid, the size, what you're trying to suction, deep versus just upper airway, whether you need like the soft neo-suckers, the flexible suction. Humidified oxygen. Why would we use humidified oxygen? To keep it from drying out their airways and just causing further irritation and inflammation. When we talk about in a minute about higher levels of oxygen, depending on the amount and the pressure and things like that, with high flow oxygen, you're going to have to do it humidified because it will cause inflammation of the nasal passages and cause bleeding and irritation. And then if they are breathing so fast for so long and they're not able to compensate, they're sucking in a lot of air as well in their abdomen. So you may need a nasogastric tube for abdominal distension. Okay. Just remember with kids, like we talked about, respiratory distress can quickly progress to respiratory failure. So just to kind of review, here's a kid in a tripod position. They're propping themselves up. They're keeping themselves leaning forward. They've got that open mouth. Versus you start to see that look in their eyes. You know, they're getting panicked. They're irritable. If they feel like they can't breathe, something's not right. You've got nasal flaring, you've got open mouth, and going from that respiratory stress, they're wide-eyed and they're fearful, but their level of consciousness, you see the kind of the difference. They're getting tired. Okay. And they've got that nasal flaring. You can see real good on that kid. Versus this kid really has decreased LOC, and their mouth is open much wider, trying to breathe. So that's kind of our progression from mild, moderate to severe respiratory distress into respiratory failure when you're looking at assessment findings. So when we're talking about increased work of breathing, y'all mentioned retractions. One of the things that you want to document and assess is where the retractions are and the severity. So mild, moderate, and severe. So are you just barely seeing them kind of flutter, intercostal, that kind of stuff? Are they sucking in air? Are they truly, like, really you can see deep, you know, as severe retractions? So you want to note where they are. Are they suprasternal, supraclavicular? When we're talking about up here, often that could be an upper airway issue. If you've got a kid with an upper airway obstruction, so if they've got croup, if they've got, you know, anything like that, what you're going to see with that, they'll be pulling in up here. You'll often see that with foreign body obstructions as well. Versus when you're looking at, sometimes you'll see some substernal with that too. When you're looking at intercostals, subcostals, a lot of times that's with lower airway. So it kind of helps you know what's going on, but it lets you know where they're having problems getting air movement through. Okay, so the most common pathways, we talked about this, cardiopulmonary arrest in children, is respiratory failure. So upper or lower airway obstruction. So upper airway obstruction, we talked about croup, epiglottitis, foreign body airway obstruction. Lower airway, bronchiolitis, RSV, asthma, pneumonia. What do you think would cause inadequate respiratory effort? Mm-hmm. Too many meds on board. They could be, you know, they could be working too long to breathe, decreased LOC. So they could have too much pain medication. They could be post-surgery, that kind of stuff. You could have some type of injury, like spinal cord injury or something like that, that would cause a problem. Pulmonary abnormalities. That's when we're talking about things like muscular dystrophies, for example. When you talk about, well, you'll get into neuro, you'll talk about Duchenne's muscular dystrophy. And everything that's a muscle, it affects. So your diaphragm, your heart, your things like that. So they get that inadequate respiratory effort. When you're looking at kids with neuromuscular scoliosis, they don't just have the curve, you know, the S curve this way. Over time, they rotate. That rotates that rib cage and compresses the lungs. So it causes them to be unable to be able to expand as well and breathe as well. That's frequently why those kids have to have the surgery and the fusion to straighten them up so they can breathe. Pulmonary congenital abnormalities like tracheomalacia and things like that, where they may have strictures in their airway, or they may have other things, fun things you don't need to worry about, but some type of pulmonary abnormality. If it progresses into respiratory failure and you're unable to manage it in other ways, then you are going to have to intubate them and then ventilate them. So red flags to look for when you're looking at respiratory distress into respiratory failure. Irritable, they don't act right. Who's going to be the best person to tell us that they're not acting like themselves? Their parent or their caregiver. So if they come and tell you, my kid's just not acting right, they haven't been acting right for days, we want to pay attention to that. They're going to be restless, because obviously if we can't breathe, we're going to be restless too, right? So you're going to see tachypnea and tachycardia. So their respiratory rate's going to go up, their heart rate's going to go up as they're compensating. When you're looking at infants and children with a respiratory rate of greater than 60, they are at risk for secondary, for apnea, secondary to that CO2 buildup and increased work of breathing. With that as well, if their respiratory rate is greater than 60, we are not going to give a kid oral feeds. Now, if you've got a kid that's in the hospital for a cardiac or a respiratory disorder and they're continually breathing at a rate of 75, are we just not going to feed them? Huh? You got to give them food. So what can we do? An NG tube? Yeah, an NG tube and IV fluids. Okay. So they can have feeds other way. They just can't have oral feeds because they can choke and aspirate on them, and that causes a whole nother problem, like pneumonia. So increased effort. So you're going to start to then progress and see, well, their heart rate was up and their respiratory rate was up. Well, now they're having retractions. They're nasal flaring. Head bobbing. You'll see that in infants as they're trying to breathe. They'll be bobbing their head. And then grunting, which is progressing to a late sign. As you move into late, you will start to see that drop in their respiratory rate, or you'll see an irregular pattern. So when you have diabetic ketoacidosis, DKA, you'll see that irregular pattern like those Kussmaul's respirations. Okay, so not a nice, consistent respiratory pattern. With that respiratory rate, remember, if they drop and they're starting to drop below normal and they're dropping, if their respiratory rate's normally 30 to 32, and they've been up in the 60s and now they're 14, they're not getting better. Okay, they're decompensating. You may hear diminished breath sounds, and you want to note where they are. Are they on the right? Are they on the left? Are they bilateral? Sometimes with asthmatics, they can get so severe and such severe constriction that they're just not moving air at all throughout their lower airways. Okay. Then they start to progress. They'll get drowsy. Then they'll have a decreased level of consciousness. They'll get sleepy. You want to look at their skin color. They may be with cyanosis. Remember, depending on their underlying skin tone, they may be blue, they may be gray, they may kind of have an ashy color. You may have to look at their mucous membranes to see that color, and then that'll progress to apnea and bradycardia. So if they're starting to have periods of apnea or bradycardia, that's very, very late. That means your kid's circling the drain. We need to do something. Things to remember: the quieter the child, the greater cause for concern. So if we went in and we had a kid and we're waiting for them to do an endoscopy for their foreign body airway obstruction because they got in mom's coin purse and swallowed, Lord knows what was in there, and she came in and told you about it, and all of a sudden the kid's, unable to swallow. Well, how would we know they're not able to swallow? Drooling. They may be chin stuck out in that tripod. Copious secretions because they're not able to get them down. They're not able to have sense of voice sound, so they can't talk to you, they can't cry. They're having increased respiratory distress. Or if all of a sudden you have that acute onset of drooling when you're worried about that supraglottic and epiglottic obstruction. So if we have a kid with anything, and say we've raised the head of the bed and we go out, and then all of a sudden we come back and we don't hear anything, that's a bad sign. We're worried about that, okay? Oxygen delivery methods. So just to kind of review this, when we're looking at kids, one thing you see a lot of times in kids that you don't with adults, you'll see this a little bit in the newborn nursery as well, is blow-by oxygen. Have y'all seen this? Yeah, a little bit. It's unreliable because you can't determine exactly how much they're getting, but basically they have the corrugated tubing hooked up to the humidified oxygen, and they've got it pointing at the kid. Now, as your kid does this and everything else, you're oxygenating their eyeballs and their ears and all those fun things, and that's why it's obviously unreliable. But they will use it sometimes post-op, things like that, just to give the kid a little extra bump and support until they wake up. It's something they can try as well if they're real fussy with a face mask or a nasal cannula and they're just trying to give them a little bit. They're not in severe respiratory distress and the parent can hold it. They can do that as well. Our nasal cannulas, we can generally deliver 1/4 to about 4 liters. If we go over that, it's considered high flow oxygen. So 5 to 8 liters, we have to do heated and humidified, and that's generally your Optiflow and your Vapotherm. You'll see that a lot with kids with RSV and bronchiolitis. Pretty much that's what we use it with. Yeah. Huh? Sometimes with pneumonia, yeah. Simple face mask, that's going to be your 6 to 10 liters versus your non-rebreather mask that has the reservoir. They say that it's about 100%. Honestly, that's really only about 95 to 97, 98% oxygen, but we're going to round that and say 100. But studies show it really only delivers that much depending on the fit of them, since all the masks aren't custom fit and they're not exactly sealed well. You're going to move then to your bag valve mask where you're providing the support, and then interim, if you're having to bag somebody, obviously you can't sit there and do that for an infinite amount of time. So one thing you can try is like BiPAP or CPAP to provide that positive in pressure, airway support. And then if that doesn't work, occasionally, say you had somebody post-op that was like a muscular dystrophy patient or something like that, and you don't want to intubate them, because once you intubate them, it's very invasive, and you start to worry about the secondary complications of ventilator pneumonia and those things. You might want to try BiPAP or CPAP until they can support themselves. Those are stuff we looked at already. All right, so if y'all want to look at your cases, we'll do the otitis media. So if you were to take your prep slides and slide them kind of into that, they would mesh. I promise they would. All right, so Helen's a 10-month-old girl who lives with her parents and 2 siblings. Her mom just returned to work because of financial reasons, so Helen and her 2-year-old brother and 3-year-old sister are now in daycare while their parents work. All 3 children were breastfed and weaned to the bottle at 7 months of age, and Helen is currently bottle fed. The family lives in a middle-class neighborhood, and Dad's been a heavy smoker for the past 10 years. Last week, Helen had an upper respiratory infection after being exposed to a child who was sick at daycare. 5 days later, she was seen in the pediatrician's office for a temp of 38.3. What do y'all think that is? 38.3 is about what? Huh? 38.5 is 101.5. So 101, 2, 3. Okay. So just remember 37 is 98.6, 38.5 is 101.5. That's generally about where we treat with kids. So they're just right under that. She was fussy. She had a decreased appetite and was pulling on her right ear and crying. When they look in her ear, her right tympanic membrane is bulging and red, and it's opaque, and they've got some purulent drainage. That doesn't look like it feels very good, does it? All right. So what do we do with this? What risk factors does Helen have for developing acute otitis media? She's bottle fed, so you've obviously got that whole negative pressure. Depending on her positioning when she's bottle fed, what are we worried about? When they lay them on their back and do bottle propping, okay? And then you have that negative pressure and that drainage sitting behind the ear and those eustachian tubes. What other risk factors? Dad's a smoker. What else? Daycare, because what do we do in daycare? You know, they touch everybody. They touch everybody and everything. So also prior upper respiratory infections, so they're already at risk. They have an immature immune system. The characteristics of the eustachian tubes, so they're short, they're relatively horizontal. Secondhand smoke from dad smoking, daycare attendance, and bottle feeding, and potentially bottle propping. Okay, what's the recent relationship between her enrollment in daycare and her condition? Kids are gross. That's a great explanation for that. Increased exposure to other children. You've got the close contact. You've got the cross-contamination. No matter how many times they wash your hands. Y'all have been at Head Start this past week, right? How many snotty noses did you see? A lot, and it's only September. Okay. Plus, they have that immature immune system, so they're at higher risk. What is the relationship between the upper respiratory infection and the development of otitis media? They're right next to each other, the increased secretions. Okay. So when we're looking at 80% of infections are respiratory related. And that's the primary, when we're looking at that, that's the primary reason that children are hospitalized. They've got those immature eustachian tubes. Like you said, they're right next to each other. They easily collapse. And then they get that fluid buildup with that negative pressure. And anytime we have fluid sitting, fluid, mucus, anything fun sitting anywhere for any amount of time, it's a perfect medium for bacteria to grow. How does passive smoke, how does dad smoking increase her risk for otitis media? And it doesn't help her upper respiratory either. Basically, it irritates those eustachian tubes and passages and linings of the upper respiratory, and it causes that inflammatory response. Yep. And I'm going to post these too. Y'all good? Are y'all good? Okay. Primary treatment for acute otitis media. What do we do? It depends on their age. That's a good point. Depends on their age. Okay. So their age range where they look at is 6 months or older or 6 months or younger. Okay. If they're younger than 6 months, being that a 6-month-old or a 3-month-old or a 2-month-old is not going to sit there and say, my right ear hurts. What are they going to do? They're going to pull on it. They're going to rub it. They're going to slap it, that kind of stuff. It's very hard to tell sometimes if that's the total issue. Plus, you're worried about hearing development, and long-term chronic ear infections can cause hearing loss. Okay, so under 6 months, they will go ahead and treat with antibiotics. If they're older, over 6 months, they will generally defer that treatment for 24 to 72 hours. Most ear infections will resolve on their own, and you can treat them with some type of antipyretic for pain, for fever, and they will resolve spontaneously. However, generally, what do we see? The kid's already been doing this for 24 to 72 hours by the time they see the doctor, so that in that case, they would go ahead and give antibiotics. Does that make sense? Okay. All right, so our choices for antibiotics. Generally, first line, they're going to do amoxicillin. Second line is Augmentin. That's going to be your amoxicillin and your clavulanic acid. Yeah, okay. Penicillins are overused. How many times, anybody that has kids, how many times have your kid been prescribed amoxicillin or Augmentin? A ton. It's the cheapest thing, but they're very overused every time. So generally, amoxicillin doesn't work anymore, especially for your kids that have had it multiple times. So they may have to try Augmentin, or they may move to something like a cephalosporin, like Omnicef. I've seen kids that have actually had to come back and do IV antibiotics, like Rocephin shots, for continued strep and ear infections. Okay. You're going to manage the pain. They can have eardrops for pain and fever. They'll do antipyretics. For kids with continued ear infections, things that they will consider is putting tubes in their ears. So that's called a myringotomy with tympanostomy for recurrent infection. And what's that going to do? Instead of those eustachian tubes having that easy collapse, they're going to put a tube in there. It's going to hold it open. Okay. Now, that comes with its own set of risks, because then you have the ear canal open while they have those tubes. So if you dunk their head and soak it in water, they're going to then get water in there as well. With chronic recurrent infections, the reason they do this is because you have the risk of conductive hearing loss. So they gave Helen amoxicillin for 10 days, and on the 9th day, Mom brings her back. Symptoms are similar to initial presentation. It didn't work. So they want to try Augmentin, and they ordered 400 milligrams every 12 hours. Those of y'all that have had med lab, I know you're having PTSD. Right? Just a little? Okay. So she weighs about 20 pounds. What is the safe dose of Augmentin for her weight? 90 milligrams per kilo per day. She's 9 kilograms. Is that what you got? Okay. So if you convert the pounds to kilos, you get 9 kilos. You're going to multiply that by 90, which is going to give you 810 milligrams per day. When we're looking at safe dose, remember we have to compare apples to apples and oranges to oranges. So we have to divide that 810 by 2 because she's getting it every 12, which is twice a day. And it's 405 milligrams per dose. Are you ready for me to shift it? And children's does round. So for example, they would round that about to 400. Okay, so when you get something and it's very close to borderline and it only has a top end and not a range, you can always call the pharmacy, ask the nurse, do they round? The pharmacist is not going to care. Call them and ask them and say, I'm just checking. When I calculate it, I get this. Do y'all round it, or do you have a standard rounded dose that you use? Okay. A lot of the times, too, if it's going to go into another, if it's something you're going to have to draw up, and they've got the little unit dose cups, if it's going to go into like a half a mil or some little minute, minuscule amount in another cup, they'll round it so it's all out of one. Okay. All right. So now let's look at tonsillitis. Questions about otitis media? So big things with that, what are you going to ask the parents when they come in with recurrent otitis media? Tell me about their day. What do they do? Do they go to daycare? Do they smoke? Does the parent smoke? Not the child. Hopefully not the child. Are they bottle fed? That kind of stuff. All right, this is going to be back on your slides. All right, so these are the down and dirty, what you need to know about tonsillitis. What is it? It's inflammation of the tonsils. The most common cause is strep. Strep is very nasty. We hear about it and we're like, okay, they got strep. But strep can cause all kinds of cardiac difficulties, can cause all kinds of renal difficulties, and all these fun things you'll hear about throughout the semester. So strep needs to be treated. Yeah. My son just has to look at somebody and get strep. It's absolutely ridiculous. I'm like, just swab him. He's got strep, I promise. So it's just such a pain. All right, so symptoms. Enlarged swollen tonsils. They can get so severe that they can have difficulty swallowing and or difficulty breathing. For kids who continually get repeat tonsillitis, they may consider a tonsillectomy and or possible adenoidectomy. And that's going to be kids that have repeat issues and repeat issues of severe tonsillitis that's going to cause the difficulty breathing. So they're generally going to use the antibiotics for strep. So that's going to be your Augmentin, your amoxicillin, your Omnicef, your Rocephin, and then supportive care. So what kind of supportive care are we going to do with tonsillitis, do you think? Huh? Yeah, soft foods, lots of fluids, because we're going to try to keep them hydrated. Now, after they have a tonsillectomy and adenoidectomy or in TNA, post-op nursing care, they're going to look for bleeding. What would we expect to see immediately post-op? What color blood and drainage? Bright red. Okay. And then we expect it to turn that rusty brown. Okay. Say a week out, we start to notice bright red drainage again. We start to worry about them bleeding again. Okay, that they've busted a stitch, that they've had, some type of issue. Another clue to look for with bleeding is frequent swallowing, because they're having it trickle and drain down the back of their throat with small kids if they can't tell you. they're going to keep swallowing because they're swallowing that drainage. So to make that easier to tell, we're not going to give them red or purple tinged fluids. So no fruit punch, no red Jell-O, no grape juice, that kind of stuff. And then no straws. Why no straws? It's going to cause that negative pressure. Okay, so that can pull clots, things like that. Anytime you have dental surgery, wisdom teeth taken out, things like that, they tell you no straws, and that's why. Okay. Questions about tonsillitis? Remember, this is where we talked about with their lymph tissue and things like that, that after the age between 8 and 12, when they start to get, that it's going to grow rapidly in childhood, and then it's going to stop. This is why you're only going to see the younger kids and generally younger school-age kids that have problems with it. All right. Okay, so we're going to talk about croup. Now, all of these are generally categorized as what they would call croup syndromes because they can present in the same way. They can manifest as upper airway obstruction. Only one of them is considered to be the traditional type of croup, and we'll walk through them. So croup can be viral or bacterial. About 50 to 75% of cases of croup is caused by the parainfluenza virus. Acute spasmodic laryngitis and acute laryngotracheobronchitis, or LTB, which is much easier, is viral. So that's going to be that parainfluenza virus, versus acute tracheitis and epiglottitis is bacterial. But the reasons they call them croup syndromes is because you're going to have these kids present with upper airway obstruction, and you're going to have to look at their history, and you're going to have to look at their clinical presentation to determine where they fall in that spectrum. You're going to have to assess the severity of that croup. So you can have mild, moderate, severe, and impending respiratory failure. With croup, you're going to have an occasional barky cough. It sounds almost like a seal bark. So if you've ever heard a kid with croup bark that have that barky cough, you will not forget that. That's a sound that's just all unto its own. They're going to have no audible stridor at rest. So stridor is going to be that high-pitched inspiratory, that type of sound. Okay. And generally no chest wall retractions. That's going to be your mild. So this kid's not going to have audible stridor at rest. They may have an occasional barky cough. And remember, they may change within their level of severity throughout the day as well. Why do kids get worse at night, generally with respiratory stuff? They've been working all day to breathe, right? They're tired. They're slowing down. They may also be laying down and trying to rest, and that's going to make it harder. So with moderate severity, you're going to have that frequent barky cough. You may have audible stridor at rest. So if they're just sitting there in mom's lap and you're going to hear that audible stridor. You'll see mild chest wall retractions, and that they're not going to be that severe, I can't breathe, that panic looked. Severe frequent barky cough as well, prominent stridor, tachypnea, marked chest wall retraction, I can't talk today, I'm tongue-tied. Marked chest wall retractions, agitation, and or distress. Versus the impending respiratory failure, that's when you have your stridor at rest, and then you're going to have the lethargy and the decreased level of consciousness and the cyanosis, so those late signs. The what? The Darth Vader, the
That always happens in the middle of the night.
Oh, of course, it does. It's wonderful. And when you're out of town and not near Hold on. Come on. I know. Run it anyway. Come on. Decide it wants to freeze. Do y'all want to take a break for a minute while it's frozen? All right. I will pause it. Okay, I resumed recording. All right, so we got this to work. Here's a picture of a kiddo with severe croup, and he's got inspiratory stridor at rest. See his whole body's moving as he's trying to breathe in. And he's pulling in up there. So he's got a little bit of substernal retraction. So he doesn't sound very good. Now he looks as happy as he can be. He doesn't look like he's having a problem. But he sounds horrible. Now, sometimes you'll hear inspiratory stridor at rest with kids with tracheomalacia and things like that. So some type of congenital malformation of their airway. So that's when you're going to look at, am I noticing other signs of distress? Do they have other history? So that's stridor as well. This is sideways, but that barky cough. I want you to look at his pupils right now. Can you see them? They're blue. You see, they're right there. You can't really tell with that one. Okay, let me see if I can get it. You're right. You'll see them right in the center right there. There, see more on that side. Okay, so he's actually getting a racemic epineb. Yeah, this is several years ago. But if you look around, he's pale. But you see his pupils now, they're pretty big. His cough doesn't sound as bad. That's Action Hank. It's not a doll, according to his father. All right. So he's had a racemic epineb, and we'll talk more about that in a minute. But I want you to look when we're talking about reversing. But you hear that cough and the stridor. It's because they gave him a steroid shot. So just some type of irritation can make them have that spasm again because they're doing that. That's why you want to be careful with them when you're poking and prodding them after they're having an issue. All right, so let's do our croup case. I think the first time he developed croup was he was 4 months old, and it was in the middle of the night. And that was my son. My husband's a Dallas police officer, and he works nights. And so I wake up in the middle of the night, and I'm hearing this noise, and I'm like, what is going on with him? And I'm like, I know that's croup. So what do? I call up to work and talk to the respiratory therapist, and I'm like, listen to him. And she's like, take that baby to the hospital. But it's a lot more expensive to get racemic epi at the emergency room than it is in your pediatrician's office, just FYI. But if you go to what's traditionally an adult ER, that's not real fun with a kid with croup. All right, during the early evening, 2-year-old Mary develops a strange cough and a crowing noise when she breathes in. She had a mild fever and a runny nose during the day. When she cries, the noise during inspiration becomes worse. The mom became anxious and brought the child to the local emergency room. So what's the crowing sound during inspiration called? Stridor. What do we think the most likely cause is in this situation? Inflammation of the upper airway, croup, LTB. Airway constriction, upper airway, croup. What other signs are common with this condition? The barky cough. And this is where we're talking about traditional croup, which is the acute laryngotracheobronchitis, or LTB. What signs would suggest that the stridor is becoming worse? Stridor at rest, that's good. Retractions, other signs of increased work of breathing. So decreased LOC, stridor at rest. Retractions, the respiratory rate's now dropping, or they're starting to become cyanotic. What is the main treatment of severe stridor? We talked about it. Racemic epi. So what's the difference in racemic epi versus like I'm going to go give somebody an EpiPen epi shot for anaphylaxis? It's nebulized, it's aerosolized, it's nebulized. It's going to focus on the airway. It's not going to be systemic. If I give somebody an IM epi shot, that's going to be systemic. Racemic epi is focusing on that airway. It is specifically for stridor. Yeah. RACEMIC. It's racemic epinephrine. Race. Now, you're still going to see, so if I give this kid with croup an upper airway obstruction, if I give him albuterol, that's not going to help. Okay, that's more for lower, mid to lower airway, versus this is going to help the upper airway constriction. Okay. Now, it's not something you would send home with a parent to give as a neb. This needs to be given with supervision. It can be given in a pediatrician or in a PCP's office or an ER, urgent care. One of the things you have to look for, so what's it going to do? It's going to make their heart race. It's going to make them jittery. Hopefully, it helps them breathe easier. But one of the things that you need to monitor them for is for like an hour to 2 hours after you give it. What you're worried about is what they call a rebound effect. And so they may revert to their pre-treatment state. So if they were severe stridor and having severe respiratory distress when they came in, they can revert to that. So that's something you want to watch for. Okay. Other interventions with this kid. What do we do with respiratory distress? Position of comfort, let him sit in mom's lap, raise the head of the bed, humidified oxygen.
Put him in the shower at night. Like we did.
You can, yeah. And so
Crank up the steam.
that's a good point. Okay, so what is the difference when we're talking about humidified mist, cool mist versus warm? We use a lot of cool. Most time we'll tell parents most of our dehumidifiers or humidifiers, things like that at home, are cool mist. What do you worry about with kids when you use the ones that are heated? Burns. Okay, so that's the big issue with that. You're worrying about burns. Now, in this case, how are we going to have to make steam in the house? We're going to have to go in the bathroom, shut the door, and turn the shower on hot. Okay, and that's going to help create that mist in the bathroom. Other things you can do with this kid: open the freezer door, stick their face in the freezer. I'm serious, it works. If it's cold outside, I know we're in Texas. If it's cold outside, you can take them outside. This is why with kids with severe croup, you don't want to turn the heat on and make it worse in the car because it's that dry heat blowing. So you drive freezing all the way to the ER, and then you get there and they're like, they sound fine. What's wrong with them? It's because they were in the cold air, and it helps soothe that airway. So in addition to the racemic epinephrine for the treatment of stridor, other things they're going to do with croup is they can give them steroids. The steroid of choice is Decadron or dexamethasone. They prefer this over like prednisolone, prednisone, Orapred, okay, be it IV, IM, or PO. Okay, Decadron's the preferred steroid. You want to keep them hydrated. So if they can drink, you're going to get them to drink. If their respiratory rate is not too high and they can drink without aspirating, if they're awake enough, you want to try to get them to drink. With kids, with anybody, you're going to hydrate better internally if they can drink versus trying to give them IV fluids. What other diagnoses should you consider with the sudden onset of stridor in a well child? Foreign body airway obstruction. They've got into something they shouldn't have got into, or choking. Now, if I've got a kid and they've got barky cough and they're not stridorous and their SATs are okay and they're sitting in mom's lap happy, do they need racemic epinephrine? No. Okay. If their SATs stop to drop, you can, put a face mask on them. If that mask being on their face upsets them, you can hand it to the parent and have them hold it. Okay. So anything like that you can do to get that humidified, oxygen blowing. All right. So with croup, with the LTB, because it's viral, you may see a low-grade fever. Okay. Anywhere from low to mid-grade. With epiglottitis, that's where you're going to be the bacterial. You're going to see that high-grade, sudden onset fever shooting up. Occasionally, they will have a higher fever with a viral form of LTB, and if that is the case, sometimes they will decide to treat that with antibiotics earlier on, just as a sidebar. All right, so Jessica's a 5-year-old child. She presents in the ER with a sudden onset of respiratory stridor upon inspiration and a temp of 102.5 or 39.2. So mom's like, she was taking a nap. She didn't feel good, and all of a sudden she woke up and she has this really high fever and she's making this funny noise. So she's drooling, and the 5-year-olds drool, generally not. So she's drooling and she prefers to sit forward with her chin slightly extended. Her mom states she developed difficulty breathing so suddenly, and both mom and child appear anxious. This is a very old picture. And this is because you don't see epiglottitis a lot anymore. And we'll talk about that. But you see she's in a tripod position. She's got that chin protruded. She's drooling. You can see kind of her whole mouth looks a little bit swollen. She came in with inspiratory stridor. She's drooling in the tripod position, high fever, sudden onset. So very sudden onset of fever and respiratory distress. That's going to be your cue that you're worried about something bacterial like epiglottitis and upper airway obstruction. All right, so are we talking about upper or lower? Upper airway obstruction. So that's going to be the stridor. That's going to clue you into that. What actions are initial interventions going to include with this kid? Let her be in her position of comfort. What else? Some O2 if they can tolerate it. So if it's a little bit older kid, they're probably going to be a little bit more amenable to that than, 3 or 4-year-old might be looking at you like, don't touch me. If it's going to irritate them worse, try to let the parent hold it or just stand back. With this kid, are you going to need to get help? So we want to establish and maintain that airway. If that means they're in that position of comfort and their tripod, you may want to try to help them get into a tripod position if they're not already in one, because that's going to help them to breathe better. You're going to limit the stimulation. We're not going to start shoving IVs in this kid if we don't have to right then. We want lots of help with us before we start stimulating this kid. Would we get a throat culture on this kid at this time? Is that indicated? What are you worried about if you get a throat culture on this kid? They're going to have a laryngospasm because they're going to go. Ugh. So manipulation of the airway can cause tracheollaryngospasm and obstruction because that epiglottis is already swollen. This is when you have like a new resident that's like, oh, I'm going to go throat culture this kid. You're going to like dive bodily in front of them, between them and the kid. It's going to be like that, slow motion in front of them. You're going to tell them, no. Go find your boss, no. All right, so what interventions should be implemented to maintain a patent airway in this child? So remember we talked about our different oxygen delivery. We talked about our different methods for respiratory distress. What may we have to do with this child? You might have to intubate, but what are we going to do until then? Is albuterol going to help this? No. You can try racemic epi, but it's probably not going to help because you've got the swollen epiglottis. You can try it, but it's not. They're going to need steroids. What else? Some type of positive airway. What'd y'all say up there? Some type of anti-inflammatory. But if we're worried about this kid having a laryngospasm, are we going to shoot him up with a bunch of stuff? Because how does steroids work? Do they work immediately? No, they work over time. So you want to get that airway stabilized first. So that's going to be your primary job. You're going to jump in between anybody that wants to stick anything down that kid's throat, unless it's an endotracheal tube. Okay? You're going to provide O2 if they will tolerate a face mask. If they are not at the level of consciousness where they're going to deal with that, or they are starting to lose their airway and they're not able to maintain it themselves, you may have to bag the kid until the doctor's ready to intubate the child. If they're in respiratory distress, they need a face mask or a non-rebreather. Okay. 2 liters of oxygen is going to do nothing for most of these respiratory disorders when they first come in respiratory distress. Just go ahead. It is not going to hurt. It's not going to hurt to put 100% non-rebreather on these kids. Okay? And even somebody that has a chronic, like we'll talk about CF, cystic fibrosis in a little bit, if they've got a chronic obstructive pulmonary disorder, it's not going to hurt them to put a little bit of higher percentage of oxygen on them for a little bit. Yes, this kid's going to go to the unit. The first thing they're going to do, though, this is one that if you get a call from school that this kid's having this problem, the ambulance needs to go pick them up. This is not I'm going to go get them from school and drive them to the doctor's office. They need to go to the ER. What they're going to have to do is, because their airway is going to continue swelling. And we can give them antibiotics, but what are you going to have when you give them antibiotics for this? You're going to have the cascade. The antibiotics are going to be like, they're going to be like, screw you, you gave me antibiotics, so I'm going to release all this funky stuff into your system. That swelling is going to continue to get worse. Okay? So what you have to do is get that airway placed first. If they cannot get them intubated in time and they can't use a smaller tube, they may have to trach the kid. And so that's the big deal with this. So you need to find an intubation set and a trach tray at the bedside. What was your question? Like a oral airway, like a nasal trumpet and an oral airway. You could, if they would tolerate it. Most kids, especially young kids, if you start sticking things in their nose and their mouth, it's going to freak them out. And you would rather them be sticking the big endotracheal tube in their mouth if they're going to freak out and getting them. And at that time, you're going to be letting them start the IV and giving them all the meds and all of those things at the same time you're intubating them. Okay. After that airway is established, then you're going to make sure you're going to give them the IV hydration, you're going to give them the antibiotics, and you're going to give them the steroids. These kids are generally going to need to be hospitalized for at least a week, and then they're going to have to go home on a couple weeks of oral antibiotics as well. Depending on if they just had to be intubated versus if they had to trach them, you know, that kind of changes their progression just a little bit. The reason you don't see this a lot anymore is because of the Hib vaccine, the Haemophilus influenza type B. Hib. Yes, ma'am.
I started in 95. I've never seen it.
You rarely see it. But this is the reason why if you have a kid that's presenting with a Croup type presentation, if they have a really high fever, remember the 50 to 75% of those are going to be viral cases. But if they present with a really high fever, they may go ahead and give them an antibiotic just in case to try to cover that, because they don't want it to get worse if that is an underlying issue. So the Hib vaccine prevents epiglottitis, it prevents some types of meningitis, pneumonia, things like that. Okay. Now, they will find a way. The best thing to prevent spread of respiratory illness, the best way is to wash your hands to prevent cross-contamination. And as you teach little kids, you know, it's very hard, y'all were at Head Start, you know this, to try on how to teach them how to cough and cover. Because what do they want to do? Or sneeze. And if they do it here, they're not immediately washing hands. I mean, these kids only have 20 minutes for recess, 15 every day when you're talking about public school. Do they have time for 22 kids to line up and wash their hands with soap and water? They should. They should make time for it. But they use a lot of hand sanitizer and things like that. They may not use it properly. They're constantly rubbing their nose and scratching everywhere else you don't want to know about. So this is why they teach them to try to cough and cover in their elbow. So don't touch little kids' elbows, because if they've been taught that, they're full of, you know, that they'll teach them like vampire cough or cough and cover in their elbow. Best thing, wash your hands. All right. Okay, so now we're going to talk about bronchiolitis. This is a nasty, nasty, nasty booger. So we have our 3-month-old male. He presents with copious nasal secretions. Copious. What does that mean? A lot. So anytime you see copious nasal secretions, you start to worry about some type of respiratory, and most of the time you worry about RSV. Okay. Copious nasal secretions and has had a fever for a few days. The infant's crying in mom's arms. Mom states the infant has been unable to eat for the past 12 hours. During your nursing assessment, you note subcostal retractions, inspiratory and expiratory wheezing. And you can hear wheezing, inspiratory, expiratory, or both. Okay. So this kid's got it on both, inspiration and expiration. Their weight is 5.9 kilos, so say about 12.2 pounds. Temps 37.9. Heart rate is 150. Respiratory rate of 52. Blood pressure is 110/70. And SATs are 93% on room air. And they diagnosed the patient with bronchiolitis. How do we diagnose bronchiolitis? Carefully. What do they do? What do they send off? What kind of test? I love it. What kind of testing do we do for bronchiolitis? Sputum. Got to get some snot, send it off to the lab. Yeah. They're generally going to do what's called a DFA culture most of the time.
Now they look at the differential.
Yeah, they may look at the differential. They may do a rapid. They have a rapid RSV as well they can do. What are some concerning things when you look at this presentation for this kiddo? What would you be worried about? They haven't eaten in 12 hours. What are we worried about? Not necessarily starving as much as dehydration. What about perfusion and dehydration is going to affect this? Could this possibly not be accurate if the kid is having perfusion issues? Because remember, our O2 sats are based on they're measuring your oxygenation based on your perfusion. So if I'm not perfusing my peripheral extremities well, that saturation, depending on where your O2 sat monitor is, may not be accurate, FYI. All right, what else is a problem? Respiratory rates, probably a little bit high. Infants are 30 to 60, 60 being more like a newborn. So we're on a little bit on the high range. What else? You've got retractions. We've got increased work of breathing. And we've got inspiratory and expiratory wheezing. Okay. Blood pressure is high for a 3-month-old. Heart rate's a little high. All right, the most likely cause of bronchiolitis is what? In most cases, it is RSV. There are other kinds of bronchiolitis. There are viral and bacterial forms. But the most likely cause of bronchiolitis is RSV, which is the respiratory syncytial virus. RSV also causes other kinds of funky stuff like pneumonia. Most of the time, if we were running around with RSV, we'd just have like a cold. Okay. Are we talking about the upper airway or lower airway? Lower, because we're talking about the bronchioles. It's also, you see the wheezing and the subcostal retractions. What other symptoms might you expect this patient to exhibit? Agitation or some change in their LOC. What else? Restlessness, irritability. Y'all are worried about dehydration, so what are you worried about there? Urine output, because what's the best indicator of fluid status in a child? Urine output. Okay, if our kidneys are perfusing, we're peeing, we're good. Okay. All right, so you might see nasal flaring, especially with infants. Yep. Yes, with respiratory distress, these kids are breathing. They've already got that increased resistance. They're already breathing. Their baseline is high. As they work to breathe more, these kids are going to be pale. They're going to be diaphoretic. You're going to see that sweat. So they're going to have that insensible fluid loss as well. That's a good question. Cool extremities. If we're worried about perfusion, as we were talking about, you're going to see those poor peripheral pulses as well, and the quality if they haven't eaten in 12 hours. Remember, it's a 3-month-old. They should be eaten every 3 to 4 hours. They may have LOC changes and decreased urine output. So what nursing interventions are appropriate for this kiddo with RSV at this time? Are we going to give this kid antibiotics? No, it's a virus. Fluids. Okay. What kind of fluids? Oral or IV, depending on the severity. Right? If they're LOC, if they're where they can drink and their respiratory rate's under 60, we're going to try to get them to drink. If not, you're going to have to start an IV. What else? What do we do about those copious nasal secretions? Suction, because is it going to help if I put a nasal cannula on this kid and oxygenate snot? No. So you're going to have to frequently suction this kid, and then that reason you may choose a face mask sometimes over a nasal cannula. When you start to use heated humidified oxygen, those prongs are a little bit bigger as well, but it's something to remember. You're frequently going to have to suction. If they start to desat, you're probably going to need to suction them and see if that fixes the problem before messing with the oxygen. Yeah. Occasionally we'll do that. It's not commonly used all of the time, depends on the severity, but that would be chest physiotherapy. And so you'll either see them use their hand or the cup, or they'll have like a vibrating, but with a small infant, they would just use like their hand or like the cupping. But it just depends on that one. What they may do when they're admitted, they may try a trial of bronchodilators on this kid, but it's less than 10% of cases. I mean, a very low percent. It's generally included on their admission criteria when they're trying to figure out what's going on with the kid. They know it's lower airway. They will do a trial of bronchodilators. In less than 10%, it works. But if it does help them, they will continue to try to use bronchodilators. If it doesn't, they won't. Okay. They use steroids very judiciously in these kids. Okay, you're having to look at the benefit and the risk. We've got inflammation, but you've also got this viral illness, and if I immunosuppress them, what's going to kind of overgrow? So they have to look at the benefit versus the risk in the case. I have seen kids put on ECMO and things like that, so that extracorporeal membrane oxygenation or that kind of lung bypass, because their RSV was so severe. Okay.
I know one thing that would help when my son got his at 3 months. I would literally stood him up in my lap and hold his little head over the humidifier.
Right, because you want to hydrate, because what's going to help loosen those thick secretions is hydration, be it cool mist, be it humidification. Like we're talking about, if we're having to do the high flow nasal cannula with these kids, you'll see they'll have that support. And so that's going to be that humidified. That's going to all help break up those secretions. So what do you have to do with these kids? It's viral. They've got copious nasal secretions. They need to breathe. You need to suction, suction, suction. They're nasal and oropharynx. You're going to have to give them oxygen in the best way they can tolerate it as needed. And then you're going to have to give them fluids to help keep them hydrated as well as break up the secretions. You're going to send a sputum culture to confirm that, and they'll wait till they get the results, but they'll put these kids on isolation when they first come in. As far as isolation, these kids are on droplet isolation. You need to wear a mask around them. As we talked about, where do kids cough and snot and everything else? Everywhere else. So remember, when you're talking about droplet isolation, if I'm just standing in the room, I need to wear a mask. But if I'm touching the kid or any sputum, I need to wear gloves and a gown. So are we going to wear gloves and a gown around these kids? Yes. Okay. That's why it says contact droplet. Okay. Because under droplet isolation, if you're going to be coming into contact with those things, you need to wear a gown and gloves. Okay. But it's droplet isolation. Okay. All right, so we reassess our kiddo, and now the temperature is 39, which is about 102, 102.1, something like that. What are we going to do? How can we cool him down? If we're already giving him fluids, what else can we do? Cooling blanket. What else? Can we give him any kind of medication? Antipyretic, what kind? Tylenol or Motrin? Tylenol. Why can't we give this kid Motrin? This kid is under 6 months old. We do not give Motrin under 6 months old. They have to be 6 months or above to get Motrin. Okay, so we're going to want to give Tylenol. I don't know why. Okay. All right. So what's an appropriate dose of Tylenol for this weight of 5.9 kilos? So here's the deal. This is just something to remember. Tylenol is 10 to 15 mg per kilo. That is just, it's not changing. It's not going anywhere. Occasionally they change the max dose per day, which now we're what, at 3,500, 3,600, Michelle? Something like that. It used to be 4,000. They cut it down. They decided that we didn't like that much Tylenol. So generally you can give it every 4 to 6. If the kid is over 6 months, frequently they will tell them to alternate it every 6 with Motrin, so they're getting something every 3. All right, so what's an appropriate dose for 5.9 kilo? So about 60 to 90, right? So 59 to 88.5. What are we going to include in our discharge teaching for this kid? Because a lot of times these kids will be snotty for weeks. They will be coughing for weeks. They may have periods where they're in respiratory distress and periods when they're not. What are we going to teach the parents? Watch your baby. Yeah, please watch your baby. Don't just let them, free range. What are they watching them for? Respiratory distress, so increased secretions. What else? Fever. Okay, fever, increasing. So they need to know the signs of respiratory distress, right? What happens? Are they going to need to bring them back in? What are we worried about? If they're having retractions, if they're having continued periods of respiratory distress. Huh? If they start to develop other types of secondary infections because they've had this issue. What else? They need to keep them hydrated. They need to watch them. How are they going to do that? How are they going to know they're hydrated? They're peeing, so they're going to count their diapers. What else? What are they going to do about all those secretions? They're going to have to know how to suction their baby. What do they generally use at home to suction the kid? A bulb suction or one of those type of, which I think are so gross, but the mouth suctions they now have that the parent can put one in the mouth and suck it. And They do have automatic ones. So they need to know whatever device they're going to use at home. So this is what you want to know. What are they going to use at home to help suction secretions? And then they need to not just tell you, not just say, I'm going to use this at home. Here it is. I'm taking it home. They need to demonstrate. They need to demonstrate that they know what to do. Those instructions about respiratory distress, are we just going to tell them? We're going to give it written. Okay. What about medications? Some of us talked about this the other day. 1 in 5 kids is dosed incorrectly, has a medication area by a parent for incorrect dosing. And a lot of the times it's because they're going back and forth between, we've told them mils and metric and all of this, and teaspoons and tablespoons. Okay? Versus, or they're using one of the cups versus a syringe. Okay? So you need to tell them what they need to use. You need to show them how to prepare it. You need to have it written on a sheet of paper. If you go in for a well-visit at a doctor's office, for a pediatrician's office, they will give you a list of appropriate weight-based Tylenol and ibuprofen dosing for your child, and they will tell you how much you need to give for that kid and its weight. It's written. They know how to give it. Okay? They said 1 in 12 ER visits is for a medication issue. It's not just reading the bottle, it's just it's confusing. Because if you sit there and they need to know how to do it both ways, or they need syringes that have both measurements, depending on how you write the dose. If I write it for 5 mils and they don't know that that is a teaspoon, and all they have at home to give it, you know, if they don't have something that's in mils, or they don't have something that measures a teaspoon, they may just be pouring up dosing and eyeballing it. You know how we look at when we're drawing up in a cup and we're looking at the meniscus and we're looking at it all, you know, they're just pouring, looking at it from overhead. You need to know that they need to, it's just a preparation, or often it's because when you get into weird where they're giving 1 3/4 of a teaspoon or something weird like that, that it's easier to give in mils if it's 7.5 or whatever. All right. You want to keep them up on immunizations because they're already going to be at risk, and then hand washing. So if this is a child, you're going to keep their siblings are not going to come up there. You're going to talk to their parents about spreading illness. Who is at greatest risk for severe illness with RSV? Babies. Who else? Specifically, what kind of babies? Babies in general, but what else? Premature babies. Pregnant mothers. What else? Elderly. Somebody, if they have some underlying issue. So like if you've got a congenital heart baby, they've already got enough issues. They don't need RSV too. But RSV is congenital heart, some type of congenital respiratory disorder. So if they're born before 35 weeks, babies in general, preemies, congenital heart and respiratory disorders. Okay. So one of the things we can do, there actually is a vaccine for RSV. It is very expensive. They have to have a shot every month during RSV season, which is about 6 months. These shots can range from a couple $1,000s a piece. Sometimes they're covered by insurance, sometimes they are not. If they are less than 2 by the time the next RSV season rolls around, they're going to need a second series of them. Okay, it's called Synagis.
Do you see the parents doing that a lot? It doesn't seem to be
They only cover it. They have to be truly at risk. They don't just do it. It's going to be a preemie. It's going to be a preemie. It's going to be a congenital heart baby. They're only going to give it, and the insurance is only going to possibly approve it or cover part of it for somebody that's at risk. And they won't cover this, is what Michelle's saying. They generally don't cover the second series. So if it's $1,000, it's going to run about $6,000 for the season. It's very expensive. But as I've said, babies die from this. Okay, so. All right, we're going to talk about asthma. When we're looking at chronic disorders in kids, asthma is the big one. If we're not talking about obesity and fun things like that as a chronic disorder in kids. Asthma is a big one. It counts for like 80% of missed school days due to a chronic illness. And as we're seeing some of the stuff that's happening this week, where we're going from 78 degrees to 99 degrees, we're in a high pressure system. We're having cool and warm front. We're having all these transitions. We're having all the fall fun things blow in the air. You're going to start to see kids show up at the ER with asthma exacerbations. So this is going to be the excessive reaction of normal protective mechanisms. So what normally happens if you are exposed, say you're cleaning your house. None of us have time to clean our house, right? But hey, we're cleaning our house because we're avoiding studying for the adult test, right? Okay, so we're cleaning our house and we stir up a bunch of dust. What are you going to do? You're going to sneeze, you're going to cough, you're going to start to get snotty-nosed, okay? That's your normal protective mechanism in response to that trigger of dust. What's asthma when you're looking at exacerbations? It's the excessive reaction of that. So you're going to start to get the bronchospasms. You're going to start to get mucosal edema. With that, you're also going to get mucus formation and mucus production, which is kind of this never-ending ugly cycle that's going to cause them to have airway obstruction. So with asthma, you have chronic and acute components. Persistent inflammation. This is why we want to manage triggers. The chronic inflammation leads to airway remodeling. So you're going to start to get a hypertrophy or a thickening of that mucosa, which is going to make it already thicker. It's going to narrow the airway. Then when you have more bronchospasm and that kind of things, it's going to make it occlude quicker. You're going to get that smooth muscle hypertrophy and the mucus gland hypertrophy, which means it's going to produce more and more and more mucus. Your airways are going to become more hypersensitive, and they need to control those triggers, those symptoms, to prevent those exacerbations. That's your chronic component. Versus their acute exacerbation is what we're going to call our asthma attack, and that's what's going to happen when they're exposed to those triggers. They're going to have a cough. They may wheeze, inspiratory, expiratory, or both. They'll be short of breath. You'll see that increased respiratory rate in response, nasal flaring retractions, and depending on the severity, they're going to have decreased air movement through those lower, that's going to progress to upper airways, to no air movement, and they may become hypoxic. So we have 6-year-old Danielle, and she comes into the community health clinic with her mom. The child presents with a history of wheezing, shortness of breath, chest tightness, and a cough that developed the previous night, which is something pretty common you'll see with asthmatics as a nighttime cough. She's lethargic and pale, and her skin is cool and clammy. She's sitting in a tripod position. Her eyes are open wide with a fearful countenance. So we start to see with all these respiratory disorders, they all present in kind of the same respiratory distress. And we have to look at the big picture and see what's going on with them. So what historical data would help us determine if this was an asthma exacerbation or if the child potentially had asthma? Now, a lot of the times they will not officially diagnose a kid with asthma until at least about 5. Because when we're looking at kids with, kids have smaller airways, they're more prone to respiratory infections and respiratory exacerbations. So they may get some lower airway issues. They may kind of term it as reactive airway disease or things like that on the way. But unless they continually have problems, most of the time they don't diagnose them with asthma before about the age of 5. So what else would help us try to figure out if this kid had asthma? Has it happened before? What's the history of it? Is there a family component? History, there is a genetic component to asthma. What else? How long's it been going on? Then, like you said, the number of times occurrences of respiratory distress signs and symptoms in the past year. Does she have a nighttime cough often? Do we often wake in the morning with issues? Other respiratory illnesses. So they have, you're trying to determine, okay, has this kid been exposed to some kind of viral or bacterial illness causing a problem in the lower airways? Any other triggers we've been introduced to? Do we have a new pet? Have we moved? Are there other environmental factors at home or school? I used to, every night when I worked nights at the hospital, that they would do the floor cleaning and they would strip the floors. I would get reactive laryngospasm to things like that, and I'd start croupy coughing, I'd start barking, I'd kind of get stridor, and it was from that. So is it some type of environmental factor causing the problem? Are you talking about upper or lower here? Lower airway. We've got the wheezing, we've got the chest tightness. We're talking lower asthma is a lower airway condition. Is this child in respiratory distress? Okay. We've got nasal flaring, retractions, poor chest expansion, cool extremities, poor peripheral pulses, and LOC changes. What are going to be initial interventions with this kid? Bronchodilator. What else? Right, positioning, head of bed, sitting, however she's comfortable. What else? Huh? Possible steroids. Depending on the issue, they'll consider steroids. Generally, with severe asthma is where we're going to have the steroids. Okay? What we're worried about is when you give steroids long term, it causes suppression. It can cause growth retardation and slow their growth and things like that. So we try not to. We try to manage the trigger and manage the issue first before having to treat severe exacerbations. Okay. All right. So you want to give her oxygen. We can do 100% via face mask. We're not going to let her lie down. How would we determine if our oxygen therapy and bronchodilators are effective in relieving the respiratory problem? What are we going to look for in our reassessment? Breath sounds. Does she sound clearer? Or is our wheezing? Are we moving air better? What else? If she can only talk to you and I can't, if she can only talk to you in one word, kind of here and there, what are you going to look for? Can she talk in complete sentences? Does she tell you she can breathe better? You're going to look at her overall work of breathing. Are retractions either, gone from severe to mild or moderate, or you're going to look for improvement in that. Do they look more alert? Are they calmer? Because obviously if I come in and I can't breathe and then we've done this and I can't, I'm going to look like I feel better. You might be pinker. They're going to verbalize that they feel better. Are y'all still writing? Okay. Tell me when you're ready. Are y'all good? Okay. All right, so when we're looking at treatment, when we're looking at asthma medications, you have two classifications, rescuers and controllers. And depending on the severity of the asthma, that's going to help guide in what you're going to use. For our rescuers, the most common thing they're going to use is a short-acting beta-2 agonist, and that's going to be your albuterol or your levalbuterol. Levalbuterol is also known as Xopenex. The majority of the time, they're going to use albuterol. It's cheaper. If they have a severe response, not just my heart is racing or, I feel funny and jittery, but if they have like a hyper type reaction of those symptoms to albuterol, they may try levalbuterol. It's like missing one of the chemical components when you're looking at the organic chain of it. And basically, it's kind of like a lower dose kind of thing. They don't get as jittery, but it may not. It just depends on the levobuterol. But it is more expensive, so frequently they don't use it as much. And then if those don't work and they want to progress to another short-acting beta-2 agonist, if the albuterol and they've been giving like continuous nebs and they're not working, they may shift to terbutaline. Other rescuer type medications with like corticosteroids, that would be like your Solumedrol or your methylprednisolone IV, or they may try to give them prednisolone or some type of Decadron or dexamethasone. Remember, though, that those are going to take time. They may have a little bit of an effect at the beginning to start, but they are going to take time to build up and last over time. With most of these respiratory issues, if they're going to give steroids, the earlier on they give them, the better effect they have with helping with that. Other things they can use are anticholinergics like ipratropium bromide, which is Atrovent. And frequently they will mix, depending on the severity, they'll mix like Atrovent with albuterol and give it in the same neb, and that's fine. If we're going to give a steroid and a bronchodilator, you always need to give the bronchodilator first. Why? So it dilates your airways and the steroid gets further down and you have a better effect. Good. So with our controllers, you're going to have a long-acting beta-2 agonist. And that's like salmeterol. And that's something they're going to have to take every day. So remember, with controllers, it's something they're going to have to take every day. It has to build up. It's a continued thing for control. Other things, they can have different types of mast cell inhibitors. They can have long-term corticosteroids like budesonide or Pulmicort, it's also known as, or the fluticasone. When you're looking at, they have some combo drugs like Advair, which includes your long-acting salmeterol and your fluticasone. And then you have things like Singular. So depending on the severity is when they're going to have all these other fun things stuffed in there. Can be delivered in different ways. You may have, like you have the propellant inhalers, which is what you're used to seeing. The Advair actually comes in a discus, and it's a dry powder inhaler. It actually has a pill with the powder in it, and they have to pop it. And what are we worried about when they're taking steroids orally or inhaled? Thrush. So what do they need to do after they take it? Rinse their mouth out. Good, good. With kids, you can either use an MDI. You always need to use a spacer. And they get out of telling adults this, and I don't know why. Because if I just hold the inhaler here and push it, where's most of it going to go? In your mouth and the back of your throat. So you really need that chamber with the spacer to actually be able to breathe in and out and inhale. And for those of you who have trouble doing things like walking and chewing bubble gum, you know, the spacer really helps with trying to use the inhaler and breathe. Now, depending on the age of the kid, they can choose the spacer versus the mask. The nice thing about the mask is it's good for younger kids. They can scream and cry and everything else, and it's still sealing that in. We don't care if kids scream and cry when they get respiratory treatments. All that does is make them go, and they just suck it all in. Okay. The thing with the mask, how do we know what size mask we need? You can measure them. They kind of have they're very soft, and so they help mold to their face well. Just with anything else, bag mask, face mask, anything else, you want kind of that bridge of their nose to the bottom of their chin. It needs to provide the coverage for that nose and mouth. Okay. You're going to do that puff. It's going to stay in the chamber. Okay. I see something. Okay. All right. Other aerosolized medications. Those are going to be like our aerosolized or nebulized medications. So our albuterol nebulizer, our racemic epi is given this way, Pulmicort, budesonide, that kind of thing. So we're going to have the nebulizers also can come with the little pipe or with the mask. Depending on the age of the kids, some of them like the pipe. It kind of gives them control and something to do versus like an infant and the mask. You can hook it up to oxygen or just the air pressure compressor. One of the things, you see how this one's open to pour it in? You can also just screw on the top and drop it in the top, especially if you're worried about dumping it once you screw it on and aren't as coordinated. If all you have is the pipe and it's a kid that really needs kind of a mask or something to blow in their face, you can always block off the other end and it'll continually blow in their face. Okay. You can run an inline into a bag valve mask as well. So here's a kid getting it with the MDI. Let me see something real quick. Okay, go back. All right, so how am I going to do this? Who has asthma? Miss Trinka, how are we going to give this?
You really want me to tell you? Did anybody else know?
Yes, you are. No, I'm kidding. I'm just picking on you this morning.
You read it. I never remember with the little kids because theirs is different than mine. So right on the side, you can see there's yellow words. And in the yellow words, it'll tell you, to shake it, put it on their face, it'll tell you how many breaths the kid has to take.
Generally, they're going to have 1 to 2 puffs of the medication, and that's what you're going to push in the chamber. You're going to shake it about 5 times to shake it up. If you haven't used it in a while, you want to prime it by pushing it before you put it in the chamber. Okay, so you're going to shake it about 5 times. You're going to put the puff in. You're going to have them breathe in. You're going to tell them to breathe in slow. And a lot of times you'll tell them to count. It gives them something to do, so they'll count on their fingers. They generally count to about 5 or 10, depending on the age of the kid. Then they need to hold their, the nice thing about the chamber is it's not necessarily if they don't hold their breath well, they can breathe in and out of the chamber. They're just breathing it back and forth and in and out because it's this nice sealed, enclosed system. If you're not using that or if they're using the pipe per se, they're going to need to hold their breath, okay, if they're not very good at it. All right, and then you need to wait 2 minutes. How many of you wait 2 minutes before you do your second puff? Good. You're doing it like you're supposed to. You're supposed to wait 2 minutes between puffs. Yeah, you are supposed to wait in between. No. Go ahead.
If you use the adult aero chamber, there's this little thing on the top that I call a harmonica. So if they inhale too fast, right, because it's supposed to go slow and deep, if they inhale too fast, it'll sound like they're blowing through a harmonica. It just makes a tooting kind of sound. And that way you can tell them, no, you went way too fast, slow and deep, or it never gets down into the lungs. It's just in the back of the throat.
And there's all kinds of neat, some have funky little face masks that look like a turtle or an elephant, rhinoceros. Some have, dinosaurs. They have a teddy bear that actually has the nebulizer fumes that comes out of its stomach. Haven't you seen it? Kind of weird, yeah. I've actually seen a pacifier that has like a little arch pot that as they're sucking on the pacifier, that's where the nebulizer comes out. So there's some different kind of things they do to kind of get the kids where they don't think it's so scary looking. Did y'all have a question over there? Okay. All right, so when we look at asthma severity classification, this is something you kind of need to look at as far as in terms of this is going to guide our treatment. Okay, we're going to use this to develop our asthma action plan. It's based on whether they're less or over 5 years old, depending on, obviously, if they're less than 5, smaller airways, we might be classified as more severe than if we were older. What kinds of symptoms they're having. Are they coughing? Are they nighttime coughing? Is it affecting normal activity? That kind of stuff. And the frequency of these exacerbations. They're going to review this every 1 to 6 months, depending on that. So they may move along as far as once they're controlled, where they fall on the continuum. Okay. So mild intermittent, that's going to be your general first level. They're having symptoms less than twice a week, nighttime symptoms less than twice a month. It does not interfere with normal activity. A lot of times these kids are going to just have their rescue med, no controller. So maybe I have mild intermittent asthma and my trigger is exercise. I have exercise-induced asthma. So rather than wait until they're playing soccer and have a problem out on the middle of the field, they would actually use their inhaler before they go play, okay, as kind of a preemptive thing, because we know that's their trigger. The rest of the time when they're exposed to those triggers, they would use that rescue inhaler. So they have no long-term meds. Mild persistent, they generally have symptoms more than twice a week and more than twice a month with nighttime symptoms. So that's going to mean they wake up coughing at night, they have trouble breathing at night, that kind of stuff. It's going to cause some minor limitations with normal activity, and a lot of times they'll have their PR and rescue meds, and they'll have an anti-inflammatory controller. Okay? So maybe, they're going to take that, daily. Then you're going to have your moderate persistent, which is daily symptoms, less than once or greater than once a week for nighttime symptoms. It's going to cause limitations. These kids are going to have inhaled corticosteroids and a long-acting bronchodilator. So they would probably be on like something like the Advair that had a combo steroid and bronchodilator, and then they'd have their rescue short-acting bronchodilator as needed. Versus severe persistent is continual symptoms, frequent night symptoms, very much limits their normal activity. And they're going to have multiple long-term control meds and oral corticosteroids. So remember we talked about with steroids, especially oral corticosteroids, they can cause that systemic growth retardation. And so we try not to give steroids unless we have to give them with kids, and we try to use them for as short a time as period as possible. Okay. When we look at anything with kids, we talk about adults, and y'all have been in rehab places and things like that, and you're looking at function and quality of life. Everything with kids is focused on quality of life and involvement and growth and development and getting them to their maximum capabilities and involving them in their care to the max possible. So our goals when we're looking at asthma management is, in the immediate, you're going to maintain their airway with that exacerbation, assess, and you're going to reassess. So every time we intervene, we're going to reassess. You have to look at the ABCs, their respiratory heart rate, their SATs, their breath sounds, and their respiratory effort. As ordered, you're going to do the humidified oxygen and the nebulizers and the other comfort measures like clustering care, elevating the head of the bed, that kind of stuff. Maintain hydration. With kids, you need to do strict I&O, be it weighing diapers, be it measuring when they go to the bathroom, what they're taking in. You're going to try to get them to drink oral fluids if they can, IV fluids if not, or if they need it as support. We're going to decrease stress if you need to keep the room quiet, keep the parents informed, group the nursing tasks. As we talked about, it's very stressful, especially when your kid's in. Are you freaking kidding me? All right. So back on the number 3, decrease stress. We talked about we're going to talk about giving choices. So when you look at the developmental expectations for the asthma management, that kind of chart, it kind of looks at, these are things to kind of consider based on their developmental age. Can you give them control of making sure they're holding, they're the ones that get to hold the nebulizer? Do they get to help just go gather the pieces? When you get into age of teenagers and things like that, can they call their own doctor for refills or call their refills in or that kind of stuff? Okay, what you would expect them to do, because your goal is asthma doesn't go away. It may not be as severe as you become an adult because you have managed the triggers or your airways have gotten bigger, those types of things. It doesn't go away though, and they still need to know how to manage that chronic illness as an adult. Things that you teach with asthma, the whole nature of the chronic state of the disease. You're going to have the remodeling, you're going to have the increased mucus production versus the acute triggers and responses and how to recognize and treat those. The medications, the schedule when they need to be given and how to give them. Peak expiratory flow readings and asthma action plan, we'll talk about those in a minute. Lifestyle modifications like trigger control, and then prevention of asthma exacerbations. So peak expiratory flow readings. It's a tool we use to look at what they're able, how much they can breathe in and out, okay? So it's going to look at the ability to push their air forcefully out of their lungs. With asthma, we're more at risk for air trapping and things like that. You're going to have that CO2 buildup. Okay, so we want to know, are they breathing in and out well? A lot of times with asthma exacerbations, you'll have that prolonged expiratory phase, that and how they're trying to push the air out. To do this, they're going to get the baseline when they're feeling good. Okay, they should have a baseline on them from when they were healthy, they were feeling good, they were not having any symptoms of an exacerbation. If they don't have that baseline with them, there is a chart that goes with these. It talks about kids, adults, men and women, size, age, all those kind of fun things, and it takes into account for it and tells you what your range should be. So if they don't have your particular range, they can get an estimate or a guesstimate on what it should be. So to do this, they don't need to be sitting in the chair like this. Okay, they need to be standing up straight. You have to set the meter to 0. They're going to take a deep breath, close their lips around the mouthpiece, and you want them to blow out hard and fast. So you're going to tell them it's like blowing the candles out on a birthday cake, or it's like a dragon breathing fire. It's not just like blowing somebody a kiss. They got to, and blowing that air out as hard and fast as they can. You're going to get the highest of 3 tries. Okay, and that's going to be their peak expiratory flow. That's going to be the maximum. So this is just an example of a peak flow chart and how they're going to mark throughout their day where they are. Kind of let you know if they're to look for certain things. If they start to get low in the evenings, well, if they're at home, is there a certain trigger at home they're getting exposed to? Yes? You just want them to get their breath back. You can wait for a couple minutes. Some will go. I wouldn't do them back to back to back. You need to at least wait a minute or so and let them get their breath back. Especially if you're trying to do it to check where they are and they're already short of breath. You want to give them a break so they're not blowing out all their air. You're going to take that number, and that's what you're going to use to develop your asthma action plan or your plan of care for asthmatics. It's based on the peak expiratory flow reading. And so anywhere from 80 to 100% is considered the green zone. 50 to 80 is the yellow zone, and the red zone is less than 50%. Okay, so if we've got, we hope their peak flow is not 100, but that's going to be 80 to 100 versus 50 to 80 versus less than 50. Okay. With that green zone, they're going to have no symptoms. They're in good control. They're just going to take their usual medications. And the nice thing about some of these colored charts is it gives them a better visual of what's going on, and it gives them symptoms of their breathing's good, they're not having coughing or wheezing, they can work, they can play, here's their regular medications, or do they only have like a rescuer. Yellow zone is caution. That's going to be 50 to 8% of their personal best. Maybe this is a day when the weather's changed and we got a rainy day or something like that. They may have been exposed to a known trigger. They went on the pumpkin patch field trip with the kids at school and were exposed to the hay on a hay ride, and so they're just not feeling that good today. They've got a tight chest, they've been coughing all night, that kind of stuff. They need to take their short-acting inhaled beta-2 agonists, and then they need to call their doctor. Okay? Versus I'm in the red zone, I'm less than 50%, the medication is not helping. So I've taken my short-acting beta-2 agonist, and it is not helping. They're starting to have more signs of increased work of breathing. They're having trouble walking and talking. This means they need to go to their doctor's office or an ER. They don't just need to call. They need to physically see another human being. Okay? If it's their PCP or it's their pulmonologist or it's the ER doc, it doesn't matter. Okay? They need to see a doctor somewhere. Okay? If they can't get a hold of their doctor, then they can go to the ER. The other things it has down here is items that trigger their asthma. So common triggers, chalk dust. They don't use a lot of chalk anymore at school, but chalk dust, cigarette smoke or secondhand smoke, dust mites. Dust mites is one of the biggest causes, the biggest asthma trigger. Commonly in dust, stuffed animals, or carpet. Yeah, we had some 20-year-old carpet that we had to rip up this summer. It was bad. I'm sure there were plenty of dust mites in that. Yeah, went to hardwood floors, much better for asthma. Sudden temperature changes, we see that all the time here in Texas. Mold, ozone alert days, when you hear that, we're in an orange ozone alert, we're in a red ozone alert. Pests, rodents and cockroaches, and not just the rodents and cockroaches, but the excrement. Okay? We had some patients with Duchenne's muscular dystrophy, and once they're missing a protein, we talked about that a minute ago, it's a neuromuscular disease. And most of these kids, it's a progressive degenerative disorder, and they pass away by their late teens or early 20s. Okay? That's their life expectancy. But a lot of times they have to sleep with BiPAP or CPAP at night. We had a family that came in, and they had 2 boys with it, because a lot of times by the time they realize that they're having problems with it about age 4 or 5, and they start to lose that muscle, they have multiple children. Okay? Girls are carriers, boys get the disease. So they came in for care management and care coordination, and they had these BiPAP, CPAP machines, and they were full of cockroaches. And every time you walked into the room, you had to flip the light on at the hospital and hear okay? So can you imagine what they were breathing into their lungs? This was their home equipment, because their home was so infested. This is their home equipment that they brought in. Their wheelchairs were infested. So can you imagine what they were breathing in? And the trigger with that. The hospital actually went out and they bombed their house, like they professionally had their house cleaned. Depending on the type of pet you have, you're going to have dander all over the house. You want to worry about where the pet is. Is it in their room? Is it somewhere they're sleeping or laying? Different types of flowers, certain types of pollen, things that are in the air. Strong odors and perfumes. This is why with kids with asthma, they're like, don't wear cologne to the hospital, don't wear strong deodorants, don't wear stuff like that, because it can actually cause them to have an asthma exacerbation. Cleaning products, and then like smoke, like say they're out camping. So here we have many asthma triggers. Other things that cause triggers, stress. So kids, they have a big test coming up. We're talking about school-age kids, this stupid STAR test. They're stressed. That can actually cause them to have an asthma exacerbation. So it may be something that you have to work with a plan with the school with different types of modifications. With the school nurse, with your doctor, and get them some type of 504 or educational adjustment, adaptive plan based on what's going on. Okay. Pollution, strong odors. If you've ever lived in like the Houston area and then come back up here, Houston is horrible with all of the plants and the pollution and that kind of stuff. And we talked about exercise. Some people have specifically exercise-induced asthma. So just to kind of give you an idea of how this allergen, just a review of how it works, you've got whatever say that's the current pollen that's in the air, and they're going to inhale that. It's going to go in their airways. It's going to cause that inflammation and obstruction. With asthmatics, and if it's their trigger, they're already sensitive to the allergen, so they're going to have that hyper reaction. And it's an IgE, antibody-mediated reaction. They're going to produce that histamine, and then you're going to get those eosinophils released. So key points with trigger management. You want to avoid the exposure to tobacco smoke. If they, for example, my kids go over to their grandparents frequently. Their grandfather smokes. He now is smoking, I guess, the vapor, which they're starting to say is just as bad, but he doesn't smoke in the house when they're there, but he smokes in the house when they're not there. So then when they go into it, they're still getting exposed to that. But one thing they can do, if they smoke outside, they can have an extra jacket or shirt that they wear when they smoke and take it off when they come in the house. Anything to try to reduce that. Don't smoke in the car with them, that kind of stuff. You want to reduce the indoor humidity to less than 50%. Okay? This is why asthmatics do better sometimes in drier. They may be okay in a hotter climate as long as it's dry climate. Like if you go to Florida in the humidity, a lot of times you'll have an asthma exacerbation. So they may need a dehumidifier. You want to wash their sheets, pillowcases, and comforters every 1 to 2 weeks in hot water. Hot water that's greater than 130 degrees is what's considered to be hot water to get rid of those dust mites. What do we normally set our hot water heater on for safety with kids? 120 or less. So that's just something to think about. Vacuum their carpets daily. We all do this, right? Yeah, sure. Other comments, yeah, your Revette vacuum. So one of the things you can do is you can remove the carpet from their bedroom. You can replace it with tile or some type of wood or laminate flooring that's easier to clean, that doesn't hold that dust into that carpet. They cannot have pets. They can get certain type of pets that are appropriate to asthmatics. But a lot of times you have that family, pet that you're not going to get rid of. It's a member of your family. So you try to keep it out of their bedroom and off the furniture or off their bed. When mold and pollen counts are high or you get that ozone alert, you're going to try to keep them inside. And then if they have exercise-induced asthma, we want them to use it prior to the activity. So if they have exercise-induced asthma, we don't want to keep them from exercising. In fact, it can help improve them over the long run in their capacity and their lung capacity and function. But we don't want that to cause that trigger in that problem. Okay. What's a really good type of exercise for asthmatics? Swimming. Why? It's indoors. What else? Huh? It increases lung capacity. It's that pursed-lipped controlled breathing. So okay, and that helps. It's really good for cystic fibrosis as well. Now, this is kind of funny listening to her, but this is talking about common exercise-induced asthma.
I just don't know what's going on. I recently tried out for cheerleading and couldn't believe it when I made the squat. I was so excited.
She's really into this cheerleading.
The problem is, I get out of breath so easily. Sometimes I start coughing. It's really embarrassing and a little scary. We're practicing outside a lot, and I feel like I can't keep up. I've done gymnastics since I was 4 or 5 and never had a problem like this. Now that fall's here and the weather's getting colder, I seem to be getting worse. I don't even know if I'll feel well enough to cheer the next game. My friends would be so upset with me if I missed it.
Tell the doctor about your medical problems.
Oh yeah, as if this isn't bad. I'm not sleeping through the night anymore. I wake up coughing and I feel like I snort. How gross is that?
What developmental stage are we in? So it's all about me. It's all about me. But yeah, that's a typical kind of exercise-induced asthma presentation with that. So with status asthmaticus, anytime when we talk about status anything, it means it is continuing on despite supportive intervention. Status asthmaticus, status epilepticus, that kind of stuff. So we've got severe respiratory distress that despite all of we're giving them continuous bronchodilators, we're, giving them 100% oxygen despite any type of supportive intervention, they are continuing to have severe respiratory distress. This can progress quickly to respiratory failure, so these kids will be admitted to the ICU. They're going to go ahead and intubate them, ventilate them, and they're going to manage it as respiratory failure because they've already got that underlying cause. They had continued respiratory distress, and it's going to put them at a higher risk for respiratory failure. Okay, so Chris is 7, and was recently diagnosed with mild asthma. He wants to play on the school soccer team, but his mom states she's afraid that all that running will cause him to have an asthma attack. How are you going to respond? Huh? He can pre-medicate them. He needs to play on the soccer team. What, in addition to the obvious of we're exercising, right, benefit, what else with a 7-year-old? Interaction with peers. And how is that good? What stage are they in Erickson-wise? They're pre-operational, but what stage Erickson-wise? Industry versus inferiority. And that gives them a sense of industry and a sense of accomplishment. Okay? So they need that interaction. They need that something that they're good at to feel that there's something that they're good at and involved with. Okay? So we want to talk about pre-medicating and then watching what's going on. Same thing if you've got a 7-year-old diabetic and they're going to be running, they're going to be exercising, you know, apply that concept across that. What are you going to do? You're going to have them eat a snack before they go run around and play soccer. Okay? Okay. Diana's a 5-year-old with severe persistent asthma. She frequently has to have neb treatments at home and school. She is non-compliant with the treatments and continually pulls the nebulizer mask off of her face and screams that she doesn't like the stupid mask. What interventions can the nurse implement? The not stupid mask? Do they have another type of mask she likes? What else can we do? Decorate the stupid mask. Audrey. Right, she's 5, so she's on that. It may or may not be as effective as if we're looking at a school age, more older school age or an adolescent that's kind of looking at other kids. But that's a thought. So have her around other kids. What else? Give her mom a fake mask. She could. She could use the mouthpiece. So can we do something else? So can we try the nebulizer mouthpiece, and does she feel like she has control over that if she doesn't like the mask in her face? Decorating, it's a good idea. What else can we do that's unmask related? Spank her? That would be wonderful. I don't think the school nurse can spank her, though. Yes? You can try to talk to her why she doesn't like it. Sometimes they'll tell you that. It may make, you know, like I said, that may be why she wants to use the pipe. She may think it's ugly. She doesn't want to wear it. It may hurt her face. It may be too small. You know, you can try to work with her on fit and other types and other things. What are some type of reward system or something you can do with her?
We can go get ice cream after we do this.
Are you going to give her ice cream every day? Multiple times a day? You could try some type of sticker chart or reward system that after she does it, she gets her sticker. And I swear, even with like 7, 8-year-olds, this does work with them. We had a cystic fibrosis kid that was literally, he was refusing to take, what was he refusing to take that day? His Miralax and his pills. He was hiding his pills in a cup under his leg. And the student was like, no, you must take them. You have to take them. And I don't understand why he's arguing. He just has to take them. And he's like fighting with the student over the pills, and they're pulling the cup back and forth. And then he refused to drink his Miralax. How many people have seen or tasted Miralax? It's nasty. And the longer you let it sit and it congeals, the nastier. It doesn't get any better from its initial state. And so he was refusing to take it. And with CF, they need to take it because they get a lot of constipation and funky stools and things like that. So he was refusing to take it, but he had a sticker chart for things like to use the Nintendo DS or the Wii or the Xbox. And so if he got so many stickers, he got to go pick the game and do that with Student Life. And so we were like, okay, so what? You know, we'll go get Child Life here. We'll put your sticker on here. And he's like, how much do I have to drink? So it kind of just changed. There was his benefit. Once he got it, he could have the sticker for that, and after he got so many. Or you get a sticker taken away if you don't. Okay, so there's some different things like that. I know kids are so funny with stickers. You'd never imagine the power of the sticker. They do sometimes. Positive reinforcement, right? It's not bribery, it's positive reinforcement. Audrey? Yeah, that can do a whole, psychological fun thing where they associate food with that's the reward. And so we generally try not to do it. That's why they try to go with some type of tangible. You get so many, you go the prize box, or you can, another thing, somebody mentioned distraction earlier, and that's another good thing. Is there a show they like to watch? And if you okay, so I'll let you watch this if you do this, or you can color here if you do this. But it's got to be something that she either has to have something at home in school or something across at the school. If the school nurse is having to do it every day, something like a sticker chart with a prize box or something like that is a good system with that. School nurses do not have a fun job. Okay, Jeff is 16 with moderate persistent asthma. He comes into the ER in respiratory distress following a school field trip to the Nature Museum and Park. Upon further questioning, he reveals that he hasn't been taking his controller meds and refused to use his rescue inhaler in front of his friends. Hey, I guess it looks better to not be breathing than to, use a rescue inhaler. How should the nurse respond to this, and what interventions can she implement? Go in the bathroom and use it? Okay. Isn't it funny? As teenagers, we all want to be individual, but we want to look exactly like our friends. It's kind of a thing. Okay, what else? What about a care contract with him? How many of y'all know what a care contract is? Did y'all talk a little bit about it with communication? This works well with older kids. It puts them in an autonomous role, makes them feel like an adult, that they almost are, and they actually are agreeing that they're going to do these things. So that is an option, as well, because a lot of times they'll be like, I don't need that. I'm sitting here and I can't breathe in front of you, but I don't need that. Or, my asthma's not bothering me, because they don't want to look different than their friends. So it's either some options for how they can take it somewhere else, or it's that whole denial of having the problem in the first place, which is why they're not taking their, controller meds. And you'll see this with any type of chronic illness, you're going to see that loss of control. So you need to find some way to give them some type of control. And care contract is one way you can do that. They're just making that agreement that they're going to do those things. That's what they're treated with that respect due to an adult. Versus you can't go out with your friends this weekend if you don't. Right. They're making it's just like when you sign a no harm contract and they're, agreeing not to, harm themselves. It's just a care contract with them.
And they'll usually comply because they promise.
Yeah. Yep. It's a whole growth and development, psychological, fun thing. It's just like you sit there with a kid that is, I have a kid, and they are pre-operational. And they have not yet developed the concept of conservation of mass. So I sit there, and I give them, and I tell them how much medicine they have to take. And they're like, I don't want to take my medicine. And you take a 20 mil syringe and put 5 mils in it, or to say a 10 mil syringe and it's half full versus a 5 mil syringe that's full. They both have the same amount in it, but they're going to want the one with the less. Or if they're on a fluid restriction and I give them a full 30 mil cup versus an ounce in a big cup, they're going to think they got more fluid. Even because you can only give them so much, so you want them to think they're getting as much as they can at the time. It's just a whole, depending on their developmental stage, where they are, and it works. Or it's an option to try. All right, so cystic fibrosis, and I'll try to go through this and get you all out of here still on time. We have an autosomal recessive exocrine gland dysfunction. So autosomal recessive, that means that both parents have to be carriers. Okay, let's back up to, Bio 101. Both parents have to be carriers. Then you've got an exocrine gland dysfunction. So that's going to be anything that secretes. So mucus glands, sweat glands, things like that. It's going to cause increased viscosity of your mucus gland secretion. So really thick, thick, thick mucus. They're going to sweat out a lot, and what they're going to sweat is they're going to sweat out high sweat electrolytes. So they're going to lose a lot of sodium and things like that in their sweat. And pancreatic insufficiency, because the pancreas is going to get clogged up with those mucus gland secretions. It is unstoppable. There is no cure. What they do, there is levels of severity with CF, and basically you're looking at trying to give them productive, pain-free lives. You're trying to limit the number of exacerbations they have, but generally about 30s or 40s is their life expectancy. We have a kiddo, and he actually was hospitalized all last week, so he couldn't come, but he is now a freshman, and he's been coming to talk to us since he was in about 4th or 5th grade. And he has cystic fibrosis, and he and his mom come, and so he might get to come later in the semester if we can get him here one day, but he was in the hospitalized last week, so they were hoping he'd get out and get home. But he generally comes and talks to you about his CF. And so he's a lot of fun to talk to, but very knowledgeable. Kids with these chronic type illnesses are very knowledgeable about their conditions, and that goes into that whole when you're talking about school age, and they want to know about their disease, and they want to know all these facts, and they can tell you what's going on. So if you're looking at our picture, so we've got both of our parents are carriers, and with each pregnancy, this is the risk that the child will have CF, okay? So there is a 25% chance that they will not be a carrier, and they'll be unaffected. So no carrier, unaffected. There's a 50% chance they'll be a carrier, but unaffected with the disease. And then there's a 25% chance, or a 1 in 4 chance, they'll be affected with the disease. And that's with each pregnancy, okay? Okay, so CF pretty much affects almost every system in the body. So starting with the lungs, we've got that buildup of that thick mucus. Remember, we talked about any time something's thick and sits there, it's hard to get out. The longer it sits there, they're at a risk for infection. A lot of these kids carry around MRSA, Pseudomonas, Aspergillus even, all kinds of funky yuck in their sputum. Because of this, you're not supposed to have a CF patient within 3 feet of another one due to the risk of cross-contamination. So these kids all have to wear masks, face masks, when they're on the unit and out of their room, because you don't want one giving their friend their fun stuff. Because of the risk of cross-contamination with all other chronic illnesses, you have a lot of family support groups and family camps and kids camps, and you can go to spina bifida camp for your kids with spina bifida, or they don't have CF camp because of the risk of cross-contaminating these kids with infection. So a lot of them just participate, in normal activities without a problem. It's just when they're around other kids that are sick, they're at high risk. So many of these kids are on antibiotics prophylactically, and they will frequently come into the hospital every so often, depending on what type of exacerbation they're having, for like a pulmonary tune-up. They have to have daily, we were talking about the cupping on the back earlier with some of the stuff. They have to have chest physiotherapy, CPT daily. With the infants, they will use their hand, or they'll use like a little cup, or they'll have like a little stick and it's got a little cup on the end. And with the older ones, a lot of times they'll have the vest, the full vest that vibrates to help break that up. They will have nebulizers they'll have bronchodilators to help open up their airways. They will have, frequently they'll have corticosteroids to help with inflammation. They will also have an inhaled nebulizer that's called like Pulmozyme. It's an inhaled enzyme that helps to break up the mucus in their lungs. Okay. Cystic fibrosis is a chronic obstructive pulmonary disease. So some of the things that you've seen with patients and talked about with things like emphysema, you'll see those same types of things with cystic fibrosis patients. You will see them develop a barrel chest over time, depending on the severity. If they have had impaired oxygenation long enough, you'll see clubbing of their nails, their fingernails and their toenails. They will have to have oxygenation for that. A lot of the times we will put oxygen on them if they're dropping in the 88 or something like that, but it's not uncommon, or, it's normal for a kid of CF to walk around with stats of 95. It's not, abnormal. Okay. Any questions about the respiratory component? Yep. Okay. Okay, so a lot of times with CF, it's diagnosed now prenatally. It is included, they have the neonatal screen that y'all do a little blood spot test, okay, from OB. It used to not be included on that, and now it is. They've increased the number of things that screens for. If it is not diagnosed prior to birth, frequently they diagnose it at birth. There are occasional times that they don't, a lot of times they've had testing and both parents know if they're carriers or that type of thing in screening beforehand. When you look at a chart of a kid with CF, you will see if they have been diagnosed with or without a meconium ileus, which means they had an ileus and they never passed their initial meconium stool. And that doesn't happen in all cases. It's a smaller percent of cases, but that's one of the first things, earliest signs that they will see after birth. One of the most common signs they see with that is because those bulky stools with CF kids is like a prolapse rectum. They generally diagnose this by the age of like 3. These would be the kids that come in with chronic respiratory infections, but also failure to thrive. So anytime you have an infant come in with that general diagnosis of they're underweight, they look sickly, they had some constant kind of illnesses, they look at them and they work them up for cystic fibrosis, they work them up for congenital heart disease, they work them up for things like celiac disease where they have that intestinal malabsorption. Okay, so most of the time they diagnose them for age 3. We actually had a kid that came in at 5 or 6, and she actually came in for a prolapse rectum. And she had frequent respiratory infections a couple a year, and they had already diagnosed her kind of with asthma, but she had CF. It was one of the older kids that I've ever seen diagnosed with it. But most of the time they do catch it early on with them. So with their GI system, when you look at all of that thick mucus blocks, we said clogs up their pancreas. It makes them have those frothy, fatty stools, the kind that sit on the water, that kind of stuff, because they're not absorbing the fats like they need to. They're excreting it. So what's going to help them break those up and absorb those nutritionally is some type of pancreatic enzyme, which frequently is pancreolipase, or there's different ones like that. Those have to be given with every meal, depending on the amount of fat in the meal. Like if they're going to have pizza or something like that, they need more than the other. There's very few things that they can have, like apple juice and some sodas and some things like that without taking them. You can't heat them up. Okay, you wouldn't heat them up in a bottle. There are some liquid formulas for cystic fibrosis kids that include it for babies, but you wouldn't heat it up in a bottle and give it to them. You wouldn't heat it up in food. You'd just mix it in a lot of times with applesauce or with their food, and they would take it. We did have a little girl try to pour hers on a hamburger one time. And the student's like diving, and you're seeing pling, 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 because it's a capsule that has all those little in it. And it just, no. It was not fun. We had to say, no, you can't do that. Mom had left, and so we were trying to feed her. She was kind of fun. So over time, all of that scar tissue, all of that mucus will build up scar tissue in their pancreas. So frequently you'll have these kids also have diabetes. And it's because their pancreas isn't functioning because the mucus blocked it and it built up scar tissue. Yep. If they're siblings, they would still cross-contaminate each other. So at home, if you have 2 kids with CF, they're still going to cross-contaminate each other if you don't keep them apart. Mm-hmm. You can't. You try your best, and you try to keep a mask on them if they're, one of them is actively infected with something. But a lot of times they're colonized with something permanently, and if one of them has it, they probably both have the same thing. But yeah. But that's the issue with things like that. Mm-hmm. Huh? Secondary infection. and the scarring builds up in the lungs. So the severity, the number of infections they have, the severity over time will build up that scarring. Their lungs will not function as well. They can have a transplant. Most transplants then are only good for about 10 years. So depending on the age you get them to, by the time they actually are on the transplant list and they get a transplant, and if they don't reject it and all those other associated things with transplantation. Yep. Huh? Lungs. Lung transplant. Sorry.
So, it just could be the genes that work, we just don't know, but what causes all the mucus to mutate like that and just get real thick?
It's an exocrine gland disorder. Exocrine, so excretion of sweat, mucus, that kind of stuff. So anything, so all along your bowel, along your GI tract, all along your respiratory tract, anything that excretes mucus, mucosal lining. So with their abdomen, because of all of that, they also have intestinal malabsorption. So they're not absorbing the fluids they need. So these kids need increased calories up to like 150 to 200%, so 1.5 to 2 times their daily caloric requirement. You know, when you have a cold and you're all stuffed up, do you want to eat? So these kids feel like that all the time. So can you imagine how hard it is to get 1.5 to 2 times what they're supposed to eat down? Yeah, so these are the kids that can have a Big Mac double cheeseburger every day. Throw some more enzymes in there. You're going to let them eat whatever they want when they want to eat it because they need to grow. Oftentimes they will have a Mickey button. They'll have a gastrostomy tube, and they will be getting supplemental feeds as well at night, or they'll have like Boost shakes 3 times a day or something like that to help get those calories in. Because of the malabsorption, it's fatty stools. They're not absorbing the fat-soluble vitamins. They will need to take the vitamins. That's why they take their pancreatic enzymes to help break down and absorb. Whoop. Go back. But they do need vitamins A, D, E, and K, which are the fat-soluble vitamins. And these kids will generally be 1/2 to 3/4 of the size of other kids their age. They will look a lot younger than they are because they have growth retardation due to that malabsorption. Okay. They have reproductive problems. Not only do you have the decreased life expectancy, but those are also exocrine glands, and so you have blocking in the vas deferens and things like that, and so often males are sterile and females have reproductive problems with the thick mucus. With the skin, we have that increased loss of sodium chloride in their sweat. So not only are they salty, a lot of times with infants, the parents said, okay, I kissed my baby and they were salty, or something like that, but they're at that risk for dehydration and that fluid and electrolyte imbalance. So if we take this kid out in the heat and they're sweating out all their sodium, what are we going to need to do? Gatorade, salt supplementation. They may have to take salt. You want them to eat salty foods that day. Okay, that kind of thing. Okay. So what questions overall do y'all have about CF? They can test. You were asking about how early. One of the things they do to diagnose that it's not good in infants, I want to say under 4 to 6 weeks, it's in y'all's first initial packet. They can do a sweat test, which basically they have a pad and it pushes in and they test the amount of sodium chloride that's excreted through their skin, but they can't do it in really young babies. So a lot of times they just have to do the blood test and the blood screen. What else? Yep. The new set of lungs doesn't necessarily take on the characters of CF, but you've already got the breakdown of the rest of the body. Right. Exocrine gland problems. So you can still have, yeah, they still have problems, but it's like the new set of lungs isn't going to have like CF per se, but they will still have the other problems going on causing the issue. And we know anytime anybody gets a transplant, they're kind of in a weakened, state, and you're already these kids are already prone to infection, and then you're giving them anti-rejection drugs. These are just looking in a reflection, and I can let y'all go through these if you want, about developmental issues with kids, and we're looking at, for example, an infant and their trust versus mistrust the caregivers are unable to protect them from medical treatments. So, you have issues on the parent side and on the child side in the sensory motor, stage. So when you're looking at this type of age and what's going on, this is just, y'all can use these as a review if you want, okay? Because I'm going to post this. And if y'all have questions as you go through, you can ask me. You're going to do all the shock stuff next week, right, Michelle? And you're going to talk about difference in anaphylactic and dehydration and all that. Okay. All right. I'm going to post this, and y'all can look at it. If y'all have any questions, there are review questions on there. As you're going through the review questions, look at them from the perspective of, if I can sit there and discuss this with you, I think I have a pretty good grasp of it. As you look through it, I know this is not your focus tonight. But as you look through it, if you have questions, please shoot me an email and let me know, and I'll be happy to try to clarify and go with you over it. My slides will be posted, and we do have integrity. Okay? As far as testing, when y'all look at respiratory distress